Good evening, everyone. This is Dr. Murali Bharadwaj, your classmate in NEET PG, FMGE, any exam in medical school. I am your everyday batchmate, roommate, dining table mate, and the reading room mate. Today we'll have discussion on some of the slightly clinically oriented practical algorithms which are often tested in the NEET PG and FMGE. So nowadays I am falling in love with all the handwritten notes because that gives a personal connection between me and all of you. I hope you are all in our WhatsApp study group. If you are not yet in the WhatsApp study group, please call our helpline 900868 and become part of our WhatsApp study group where we will be intimating every time the class begins. Now, gonadotropin releasing hormone. There are antagonists and there are agonists. In different clinical scenarios, we use either antagonist or agonist. If you give antagonist of the gonadotropin releasing hormone, there is a fall of LH, FSH, and that in turn will decrease the estrogen, progesterone, testosterone level. So in any clinical condition where excess estrogen or excess testosterone is unwanted, that is the situation where you require to use a GnRH antagonist is what you need to remember. Very good to see Bhargava Pasupuleti, our companion in this midnight masala class. As I told you guys, please click on the bell button after you subscribe on this YouTube channel and also be a part of our WhatsApp study group so that every time we are starting a class, extempore class like this, we will be sending an intimation. Very nice to see almost 10 online students. Now doctor, carcinoma prostate and endometriosis. These are the two situations where you don't want estrogen, don't want progesterone, don't want testosterone. That is the reason we use the GnRH antagonist. Gotcha? Good to see Avi, Sushmita and many more who are all online. Thanks for joining in this midnight masala handwritten notes revision with Dr. Murali Bharadwaj. Now, what are the various GnRH antagonists? You should be very sure on the pharmacology. Eberelix, Elagolix. Tell after me. Eberelix, Elagolix, Relugolix. Cetrorelix, Degarelix, Ganirelix. Now, these GnRH antagonists differ by the route of administration. We give Eberelix intramuscularly, Elagolix, Relugolix orally, Cetrorelix, Degarelix, Ganirelix subcutaneously. You should not forget. If you see the recent aims, PGI, NEET PG, JIPMER, FMGE, this is a very important topic, right? So you should be very sure. Now doctor, what is the story of GnRH agonists? Either you can give them non-pulsatile by administering them daily, or you can give them pulsatile physiologically, just the way physiologically they are produced pulsatile. If you administer every 90 minutes, it is like a pulsatile administration. If you give them non-pulsatile, they have an inhibitory action. Though they are GnRH agonists, if you give non-pulsatile, they will have an inhibitory action. They decrease the LH and FSH, they decrease the estrogen, progesterone and testosterone. So where do we want to use in non-pulsatile way and decrease LH, FSH and decrease estrogen, progesterone production, doctor? If there is a precocious puberty, I don't want this precocious puberty, I don't want estrogen. Give a agonist, non-pulsatile way. Endometriosis, estrogen dependent condition. Give it in a non-pulsatile way, the GnRH agonist. Then fibroids, they are also estrogen dependent growth. Try to give them non-pulsatile way. Similarly, in case of men, prostate cancer, it is testosterone dependent. So give GnRH agonist, but in a non-pulsatile way. Got it? Now, if you give pulsatile administered every 90 minutes, you are increasing LH, FSH, you are increasing sex hormone production, you are stimulating the production of estrogen, progesterone, testosterone. Where do you want it? If there is a delayed puberty, I want estrogen, I want estrogen, I want to become puberty. So there you use pulsatile way, pulsatile way. Similarly, if there is any anovulatory infertility, like polycystic ovarian disease, then also you require to stimulate the LH. That's the reason you pulsatile GnRH agonist is what you need to remember. So what are the examples? What are the drugs which are called GnRH agonist, doctor? Neferilin, buserelin, goserelin, luperelin, triptorelin, historelin, all relins are agonists, all golics are antagonists. Barabar? Now you all became expert in this area of GnRH. Tomorrow's exam, you should be 100% sure, doctor. Now, let us talk about vagina, epithelium of vagina, maturation index. This is one of the favorite topic of the examiner. Let's talk about it. Basically, vaginal epithelium has basal cells and parabasal cells, right? Then if you look at the basal cells, they are the main type when there are no hormones. If it is menopause. Wow, Ashish Pandey! Ashish Pandey, I'm so happy, so happy. Good morning, sir. I passed FMGE because of your guidelines and your teaching. Thank you so much. Ashish ji, thanks for the kind words. But let me tell you, you passed because you have that willpower. And today you made my day. Right? So, I'm so happy. And welcome to the journey of NEET PG also. NEET PG also, Ashish. God bless you, beta. Out of 13,000 people who write the exam and only 3,000 to 4,000 who pass, हमारा आशीष भाई आज शामिल हो गया, and he is in the next part of the game, right? So shortly नीट पीजी का रिजल्ट आएगा, हमको लड्डू भेजना व्हाट्सएप में, बाबूजी, ओ डॉक्टर बाबूजी. Now I'm so happy. So doctor, in vaginal epithelium, whenever progesterone is dominant, after ovulation, corpus luteum keeps on producing progesterone. So when progesterone is dominant, the second half of the menstrual cycle, that is post-ovulatory, then you will find intermediate cells. Even during pregnancy also, when progesterone is dominant, intermediate cells. When estrogen is dominant, that is in the first half, pre-ovulatory part of the menstrual cycle, estrogen is very high, then superficial cells will be dominant, is what you need to remember. Right, doctor? Now, what is meant by maturation index? A, B, C. A means parabasal cells for 100 cells counted. B is intermediate cells. C are superficial cells. Right? Now, at birth, the A, B, C index. At birth, there are no parabasal cells, but we have intermediate cells and superficial. 95 by 5, 0 by 95 by 5. In the childhood, parabasal are dominating, 80 by 20 by 0. 20 क्या है? B. B means intermediate. Okay. Now, in the reproductive period, that is pre-ovulatory, mid-secretory, it is 0 by 40 by 60. That means intermediate cells are 40, but superficial cells are 60 because they are estrogen dependent. Right? Then mid-secretory, that means after ovulation, 0 by 70 by 30. 70 is what? B. B means intermediate. Right? So 70, intermediate are predominant. So progesterone is predominant in the mid-secretory phase. During the pregnancy, it is 0 by 95 by 5. 0 by 95 by 5. Once more, estrogen, progesterone, both of them are predominant, but intermediate cells, which are typically progesterone dependent, they will be predominant in pregnancy. Postpartum, it's called parabasal maturation. 100 by 0 by 0 is what you should remember. Similarly, postmenopausal, there is no estrogen, bilkul nahi hai estrogen. That is the reason it is 100 by 0 by 0 is what you need to remember. Right? That means parabasal cells, once more, are predominant in the postmenopausal, just like they are predominant in the childhood. That is the point you need to appreciate. Chalo bhaiya, hum abhi maturation index mein bhi expert ban gaya. Chalo. Now let us look into how is the vagina developed. A very interesting development, a very favorite hot question for the examiner, which you have to be very sure. Good to see Shivam Panchal, who is also online. So please tell your friends our 45 Sundays live online broadcast and face-to-face live in Hyderabad every Sunday 9 a.m. to 5 p.m. is starting from January 26th. So ask your friends, juniors to also subscribe. Just for a throwaway price of 10,000 rupees, you get a opportunity to get 360 hours of revision, 2 revisions in fact, 2 cycles of revision. Right? Now, vagina, how is it developed? Upper 3/5 above hymen, lower 1/5 below hymen. Above hymen, upper 3/5 is developed from the utero-vaginal canal of the Mullerian duct. Finally, Mullerian ducts are important for the upper 3/5. Right? Then, lower 1/5, it is the endoderm of the urogenital sinus from which the lower 1/5 is being developed. Now, if you look at the mucous membrane, musculature, hymen, how are they developed? Mucous membrane develops from the endoderm of the canalized vaginal plate of the sino-vaginal bulb, that is urogenital sinus. Okay? Whereas musculature develops from the mesoderm of the fused caudal vertical end of the Mullerian duct. And the hymen basically develops from the junction of the Mullerian tubercle, which is mesoderm, and the sino-vaginal bulb, which is from the urogenital sinus. That is the hymen ka आविष्कार की underlying embryological basis. Good to see Prince. Good evening, boss. Absolutely. Boss is always correct, right? So, doctor, I really appreciate any day, any time of the year, even at midnight also. I was just checking how many of you will be awake and join the class. Still, around 15 to 20 of you have joined the class. I'm very happy. Now, doctor, vaginal introitus. The vaginal introitus is developed from the ectoderm of the genital folds after the rupture of the urogenital membrane, bilaminar urogenital membrane. So, one of these is a favorite MCQ, doctor. Embryology of vagina is a favorite area. Now you have become experts. Now, doctor, time aa gaya. Hirsutism. You got a patient. She is very unhappy because of the excessive growth of the hair. All her classmates are bothering her in the ladies' hostel. She came to you, and you need to discover what is going wrong for this excessive growth of the hair. So, diagnosis is like Sherlock Holmes. Whether it is endocrinology, whether it is gynecological endocrinology or general medicine, doctor, be very sure. So, hypertrichosis it can be. Few people naturally are born with too many hair follicles and they grow a lot of hair. It can be a normal phenomena, normal developmental phenomena, or it can be hirsutism. Whenever hirsutism is there, look for the virilization, signs of virilization, like clitoromegaly, etc., etc. If there are no signs of virilization in a girl who has hirsutism, you get the history. How are the menses? Normal or irregular menses? If there are irregular menses, get a thyroid function test. If it is abnormal, treat the thyroid dysfunction. Very treatable condition. You are a very happy guy. Always when an abnormal biochemical value comes, in fact, you need to be more happy because you can treat it. Now, suppose thyroid function tests are normal, let us say. Then the possibility is there are irregular menses, no signs of virilization, but thyroid function tests are normal. You should look for polycystic ovarian syndrome or congenital adrenal hyperplasia or anovulation. Any of them are responsible. Similarly, when irregular menses are there, also get a prolactin profile. If it is normal, prolactin normal, thyroid function test normal, that is a possibility only if it is congenital adrenal hyperplasia or PCOD or an ovulation, if that is responsible for this irregular menses and hirsutism without virilization. Of course, congenital adrenal hyperplasia can cause virilization, need not cause virilization. Both the things are very much possible. Let us say prolactin is high. That is, irregular menses are there, prolactin is high. Obviously, high prolactin is causing an ovulation, and ovulation is causing irregular menses. And that is the underlying cause for her hirsutism. So you do the neuroimaging of the pituitary, ovaries, imaging of the ovaries whenever the prolactin is high. Now there are signs of virilization, let us say, clitoromegaly, etc., they're all there. In a girl who is having excessive hair growth, which is hirsutism, which is not hypertrichosis, which is not normal, then you check for the male hormones, dihydroxyepiandrosterone, testosterone and 17-hydroxyprogesterone. And you do a imaging for surgical exploration, right? So typically, if there is virilization positive, and when you check these, you will discover that underlying adrenal, virilizing adrenal tumor or ovarian tumor, anything can be responsible for this presentation of hirsutism and virilization. Image and do surgical exploration. Now, there is hirsutism, no virilization, but menses are normal. Menses are normal. Then you get serum testosterone and 17-hydroxyprogesterone. Serum testosterone is less than 200, right? Then it is anovulation. Anovulation will lead to serum testosterone elevated but less than 200, and it may still lead to normal menses without virilization and hirsutism. If it is more than 200, then you do a pelvic examination. There may be an adnexal mass, any virilizing tumor, you need to surgically treat that. That's how you approach. Then you look for, once more, there is hirsutism, there is no virilization, there are normal menses, and when you checked the 17-hydroxyprogesterone, you found that it is less than 200. If it is less than 200, 17-hydroxyprogesterone means it is unlikely to be a virilizing congenital adrenal hyperplasia. In congenital adrenal hyperplasia, 21-alpha hydroxylase deficiency is a virilizing type of CAH. But there, the 17-hydroxyprogesterone levels are high. If it is less than 200, it rules out the virilizing CAH. But if it is more than 200, you do ACTH stimulation. If the ACTH stimulation is leading to suppression less than 1000, that means it is a heterozygous carrier state of 21-alpha hydroxylase deficiency. But if the ACTH stimulation is unable to suppress, means it is a late onset congenital adrenal hyperplasia of virilizing type, which is due to 21-alpha hydroxylase deficiency. That's how you clinically approach. So your main investigations, doctor, your main observations are virilization, there are not. Menses, there are not in the history. Your main investigations are, and the diagnosis are, abnormal thyroid function, prolactinoma, congenital hyperplasia, PCOS, anovulation, etc. etc. Barabar? Ek baar you sit with your friend, think that you are the gynecologist practicing in London, MRCOG. 1 to 2 times if you do rehearsal, you are the master of this algorithm, right? After all, there is a pituitary, there is an ovary, there is an adrenal. That's all we are talking about, right? Now, doctor, let us talk about the next favorite algorithm that you have to be very sure about. Mullerian agenesis. Very good to see Nagambika and many more who are all online. Thank you for joining in this late evening. Mayer-Rokitansky-Kuster-Hosner syndrome, a tongue twister that can lead to fracture of the tongue if you don't properly pronounce it. It is a Mullerian agenesis. Basically, Mullerian agenesis, underlying genotype is a female. Why is it? Who is the close differential diagnosis for Mullerian agenesis? Even testicular feminization syndrome, which is also called androgen insensitivity syndrome. Even those people also have a blind ending pouch-like vagina. That is the reason you should know. If it is testicular feminization syndrome, there it is 46XY, whereas MRKH syndrome, the genotype is 46XX, is what you need to remember. Online students, please punch whether my voice is loud and clear. Is there any echo or reverberation, or is it clear? Can you kindly punch, is my voice loud and clear? Now, if it is a MRKH syndrome, Mullerian agenesis. Thank you, Saurabh, for saying it is clear. Excellent. Also, guys, please write a comment underneath this video. There is a comment section. I always enjoy comments. I see a lot of other teachers, their videos get a lot of comments. My videos don't get comments. Comments are compliments, doesn't matter. That makes me really feel sad that am I too good or am I too bad? What's the reason for no comment, right? So please write a comment whether you are liking this handwritten notes. That is what I'm going to give you this year. Personally, like a hand woven Kanchi Kamakshi, Kanchi sari, right? We are going to create the notes handwritten and going to study together, right? So please write a comment in the underneath every video. Also add some points that you liked or you wanted to add underneath the video after it got published. That will help us a lot. Now, doctor, in Mullerian agenesis, Mullerian duct is responsible for fallopian tubes, uterus, cervix, and upper vagina. They are all absent if there is a Mayer-Rokitansky-Kuster-Hosner syndrome, which is Mullerian agenesis. So that is the reason, if there are no fallopian tubes, if the upper vagina is missing, how can menstruation can occur? Thank you, Saurabh, for the compliment. Please write the same compliment underneath the video when it gets published. That makes a great difference. Thank you so much, Saurabh, for kind words. Now, because of that, if there is no fallopian tube, if there is no upper vagina, then uterus, then they present with primary amenorrhea. And always for Mullerian agenesis, investigation of choice is ultrasound. And how do you treat? You need to reconstruct the vagina. To menstruate, to become pregnant, to produce children, that is all different story. But to enjoy a happy conjugal sexual relationship, that is most essential part of life. So McIndoe's vaginoplasty need to be done, where reconstruction of the vagina need to be done, and preferably before marriage or after marriage, doesn't matter, when the woman starts the sexual life. Now doctor, in Mullerian agenesis, ovaries are normal. Ovaries have nothing to do with Mullerian diet, because ovaries develop from the genital ridge. That is the reason they will have normal estrogen, normal secondary sexual characters, normal breast, normal female phenotype, and they have a normal ovulation happening. So that is the story you should remember about the Mullerian agenesis and Mayer-Rokitansky-Kussner-Forstner syndrome. Time for a quick advertisement, doctor. Once more I want to tell you, NEET PG 2021, FMGE June, December 2020, hot prep with Dr. Murli Bharadwaj. 45 weekends, Sundays, 360 hours total live preparation. Every Sunday 9 a.m. to 1 p.m., 2 p.m. to 5 p.m. January 26 to June 21st, cycle 1 round of 19 subjects are revised in 21 Sundays. June 28 to November 30th, another cycle of 24 Sundays, 19 subjects revision. And it is a live session, face to face in Hyderabad. Please join. I love to see hundreds of you, and we all studying together every Sunday, and live online interactive everywhere. Suppose you are not able to come to the live class, still that live is being broadcasted into the onlinembbs.com. So you can be able to participate and do the revision. The fee is cheapest, most affordable. The main idea is you require coaching to stimulate you to study. So it is only 10,000 rupees. Please call 900868 to join today. And January 26th, I love to see all of you in the live anatomy prep morning 9 a.m. to 5 p.m. Now doctor, let us quickly jump to the handwritten notes. That's what I'm going to give, a lot of handwritten notes. Now let us quickly do a revision of 10 points. Now I am coming up with a 400 pages of totally 2000 high-yield points for the NEET PG FMGE in each subject. Now let's quickly talk 10 points about vertebral column for the tomorrow's exam. Vertebral column has 33 vertebrae. Cervical C1 to C7. Thoracic T1 to T12, lumbar L1 to L5, sacral S1 to S5, coccygeal 1 to 4. Now, what does vertebral canal contain? It has a spinal cord on it. Basically, it is carrying spinal cord. There are dorsal rootlets. Dorsal is sensory, ventral is motor. So, ventral rootlets. dorsal nerve roots, ventral nerve roots, and the meninges. Next, how do spinal nerve? Where is spinal nerve? Ultimately, these roots come and join, and they exit through the intervertebral foramen. Is what you need to emphatically remember. Now, few words about the normal and abnormal curvature of the vertebral column. What are those parts of the vertebral column which are called primary curves and secondary curves? So you should remember, doc. Thoracic and sacral curvatures. They are formed during the fetal period. That's the reason they are called primary curves. Then cervical, neck, lumbar, back curvatures, they form after the birth. पैदा होने के बाद, after you are born, you will be lifting the head. That makes your cervical to grow, curve to develop. You will start walking. That makes your lumbar curvature to develop, is what you need to remember. What is kyphosis? Kyphosis is a exaggeration of the thoracic curvature. Thoracic curvature. So what is responsible for the kyphosis, doctor? Osteoporosis, disc degeneration. When you become aged, you become the kypho. Then lordosis. Lordosis is the exaggeration of the lumbar curvature. And what is the reason for it? Pregnancy, spondylolisthesis, slipping of one vertebra over that of the other, spondylolisthesis. Khao, piyo, aish karo, pot belly. Now, scoliosis means lateral deviation, and what is the cause for it? Wow, Sushmita! I'm so happy, Sushmita. Sushmita Green. FMGE published, passed. So happy, so happy. I am feeling that I just got a eligibility to practice. Excellent. So please shake the hands, join the journey of NEET PG. Please give a call to our helpline and tell them, hey, I am Dr. Murali's successful student. So for whatever price that you can pay, our people will enroll you into the NEET PG and continue your preparation. And also please send a small video testimonial on the WhatsApp to our helpline. That will be a great help. Of course, we are not very commercial, but we do our commercial, and we want to set an example. By 1 lakh rupee, 2 lakh rupee, 70,000, 80,000, there is no need of wasting money. We provide the cheapest, most affordable coaching program on the online mbbs.com, and above all, we become classmate with you every day. I am very happy, Sushmita, for this wonderful result. Now, doctor, poliomyelitis, a short leg hip disease. They lead to development of scoliosis, is what you need to basically remember. Okay. Now, doc, that is in short about the various curvatures. So we are going to build a revision like this with some handwritten notes, quick points. So totally each subject में 4,000 points को पकड़ेंगे. गर्मा गर्म फोकस करेंगे, रिवीजन करेंगे और कल के एग्जाम में जीत लेके हम कामयाब होके दिखाएंगे. So that is what we are going to be. And thank you all for joining this wonderful evening, and see you all on the Sunday 45 Sunday program starting from January 26th. Good night.